Okay, it looks like we had some people in the waiting room. Not sure, normally a TA logs in earlier, so I'm sorry if you guys had to wait a little while. You can do hard things. Excellent, thanks for letting everybody in. Welcome, welcome, welcome. I'll tell you, it's a beautiful day outside. I'd rather be outside, but thank you. Oh. Hey, Aaron, it sounds like you need to mute, Aaron. Well, that was curious. Okay. All right, keep an eye on that waiting room, Hannah. Thank you. I got helmet hair.
I don't think I am a host just now, so.
Oh, thank you for telling me that. That's curious. Let me make sure that you are assigned as co-host. There you go, my friend. Delaney, I'll also make sure you are a co-host. Excellent. And any other TAs want to turn on their screen so you come to the front of the line, that would be awesome. Oh, thank you, Talon. Everybody's a co-host. That means you can let people in. You can represent me in the chat. Hi, Elizabeth. Thank you. Smiles, everybody. Smiles. Okay. All right. Well, we are in for a good time today. Again, right, when I get to talk about these topics, they're just the easiest things to talk about because psychology is just so freaking fascinating. And when we dive into and we start talking about mental health specifically, it's just the area of psychology that people tend to know the most about, or at least have the most opinions about. One of the things that I consider my responsibility / opportunity in covering this content is correcting some misconceptions. So hopefully we've gotten one of the most important ones out of the way, is that people with mental health issues are not inherently more dangerous than other people. And I think that that's really, really important. Please complete the seating survey if you are in here. Of course, I'm going to start the poll. I will be launching one of your exit tickets in the next couple weeks. Is going to be quite a bit more detailed, where I'm going to be asking you about choices and attending class versus checking in via remote. I know I've explained it to you guys a bajillion times. It's this is a lot of space, and it took a lot of money to make this space. And if I can offer a lecture to, let's say, the 25 people that have been consistently coming face to face, and then Zoom the rest, then that really changes the university capital expense. I mean, it's $85,000 to host a class in here, not every day, but it was $85,000 to get the space set up. And if I could teach in a slightly more intimate setting where people aren't up in the goddamn mezzanine, and I can actually make eye contact with a few people that are 6 to 10 feet away from me, I would be all right with that. I would be thrilled with moving this to a class of 25 people. Or 30, you know, whatever it shakes out to be. So go ahead and complete that. Make sure and do the seating survey. If you're remote, let them know you're a remote. Housekeeping, Unit 3 essay is active today. After class, you're also going to get your feedback on your Unit 2 essay. Please, 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 I cannot stress this enough. Look at your Unit 2 feedback before you start your Unit 3. In fact, set aside time to look at your Unit 2 feedback today. Give yourself 12, 24 hours if possible before you actually start on the Unit 3. Soak in the feedback, understand where you're coming from, know your targets, right? Identify for yourself what you can do to leverage and move forward. I had lots of full point essays this round. In fact, I think I had more full point essays this round than I did in Unit 2. But as I mentioned on Monday, there's some there was this sort of glaring absence of some content that we had in the prompt from a lot of people. So while we have more on the upper end, we definitely have more on the lower end as well. And we'll keep talking about that. So definitely look at your feedback on that. And Unit 2 grades will be posted after class. Any other housekeeping? Anybody want to pop something into the chat and let me know if there's a housekeeping, a research related, anything that you feel would be helpful to know, see, understand? Okay, good. I still can't complete all my research credits. So I talked to the director of the research in our department, Dr. Stone, and there will be more studies posted on the week of the 18th, I believe. So he's got it set up. We have a few more studies that we know are in the pipeline from student researchers, and those should be showing up this week and next week. And then if they are not here, by next week, they have research to graded. Audrey, I just made an announcement about the Unit 2 essay. You will be able to see your score after class today. Excellent. Braxton asked what content was missed. A lot of people who did the memory prompt did not include any learning theory reflections or integrated insights. So that was something that was missing pretty consistently. And those people who did the developmental prompt, a lot of people left out cognitive science. They addressed physical and social emotional, but they didn't include cognitive. All right, I'm going to close my chat and move on to content. We have more questions here. The learning outcomes. We have a few more questions from exit tickets. Some of this content is from Monday, and then some of this is just sort of general questions. Are bipolar disorder and bipolar depression different, or are they the same? Bipolar depression is just the depressed state of bipolar disorder. When we talk about bipolar disorder, really what we're talking about is this cyclical issue. And because of this silly little way that they have this thing set up, I want to draw something out for you folks. Okay. Well, that's not what I want to do. Let's do this. Okay, we're going to do this one. So I know you can't see what I'm drawing. I'm going to show it to you here in just a second, but because of the way I can't draw on the screen that you guys see. So here you go. Here's what we consider a normative range of behavior, right? Some positive, some negative. Can you guys see the PowerPoint slide? Delaney, will you give me a thumbs up if you can see it? Okay, brilliant. So we have this range of normative behavior. And when we are talking about bipolar disorder, what we have, actually, let me just do this one, and we'll change the color of it.
Dr. Henderson, if we're supposed to be seeing a PowerPoint slide you're drawing on, no, we do not see it.
No, I just moved the PowerPoint slide over so you guys could see the white sheet. Are you not seeing that, or?
No.
Okay. All right, good to know. So let me share this. We'll just pop between shares. All right. So you see this orange line? Do you guys see the orange line on the white piece of paper? Excelente. Okay. So what we have here is we have this orange line represents basically major depressive disorder. And with major depressive disorder, we are low all the time. Affectively, emotionally, we are low. And then what we have is we have this thing called cyclical depression, which looks a little bit like this. And that middle bar is what we would consider like normal, right? We would consider like not positive, not negative, but just sort of contentment wouldn't actually be effective either, but middle range, some high, some low. So this is what we typically experience. The majority of us typically experience something that looks like this, and then you hit midterms and it's all downhill. I'm just kidding, that's not real, but it might feel that way. So, right, like the orange line, major depression, cyclical depression is that fuchsia line, and then sort of the normal range is that blue line. Well, when it comes to bipolar disorder, what we have is we have this unique experience. And bipolar depressive episode is anything below that line, near that orange line, okay? Now, the time that it takes, okay, the time that it takes to get from point A to point B in bipolar disorder, it varies by person and it varies by circumstance. Like somebody can be in mania, like you guys saw with Mary. Like Mary was in depression, and then 3 days later, she was in mania. Sometimes people with bipolar disorder will take weeks to get from A to B. And that's the reason why when we diagnose bipolar disorder, it can sometimes take 6 months to come up with an accurate diagnosis, because we need to see this cyclical pattern in manic behaviors and then also severely depressive behaviors. So that is a great, good question for sure. Okay. Pardon me. Are all disorders genetic to start with, or can other factors play a role? There are different degrees of heritability, and heritability is the genetic explanation for a lot of disorders. When it comes to bipolar disorder, two genetically identical twins, okay? One twin has bipolar disorder. The other twin has an 80% likelihood of also being bipolar, which is huge, which tells you that there's a big genetic component. But when we look at heritability and we think about generations, like my mom, me, and then my daughters, right? If my mom had bipolar disorder, I would have actually a 65% likelihood of developing the disorder as well. And then it decreases. Well, actually, I don't know what it does for second and third generations beyond the individual who identifies with the disorder. So that's for bipolar disorder. For depressive disorder, for mood disorders, for anxiety disorders, and for thought disorders, much less heritability, right? Not as genetic. So no, not all disorders are genetic. Bipolar disorder is one of the ones that has a really strong component. And we're also seeing, we found the gene that alcoholism and addiction is carried on. So that one's pretty significant as well. But we're still exploring that area. But right now, we are going to say that there are a lot of other factors at play. Life stresses, resources, circumstances, emotion regulation, executive functioning, exposures to toxins. One of the reasons why we have our drinking age is 21 years of age is that your brain isn't done developing until you're actually 22 to 25 years of age. But what we run into is that if you expose yourself to substances, the younger you are and the more frequent you expose yourself to those substances, the more likely you are, your brain is to adapt to those substances and then start to create an expectations pattern. And if you are not fulfilling those expectations with substances, you're going to start fulfilling them with some other equally difficult behaviors. Lots of impulse control disorders like trichotillomania, the disorder, it's an impulse control disorder where an individual plucks the hairs out of their body. Another impulse control disorder is pyromania. Another one is kleptomania. And those tend to all be associated around the same issue of substance abuse. So there could also be a genetic component to that as well. How do psychologists tell the difference between one having depression or having bipolar disorder? If you go back to our Groovy Tunes diagram, right, showed bipolar disorder as this cyclical period. And again, we're going to observe somebody for about 6 months before we can provide that accurate diagnosis. Major depressive disorder, we're just down all the time. We don't have that cyclical nature of high mania and low depressive experiences. Are people that are diagnosed with one disorder susceptible to being diagnosed with another? Well, so we have this issue known as comorbidity. And comorbidity is, how can I best articulate this? Comorbidity occurs when, oh, it looks like somebody's not muted. Would you please check your microphone and make sure you're muted? Okay, so comorbidity like anorexia for middle-aged, middle class, younger white females. Anorexia is very commonly comorbid with alcoholism. So if you have anorexia, you have a high likelihood of also having alcoholism. We see a relationship between mood disorders and anxiety. A lot of people who are depressed have anxiety, but not everybody who has an anxiety disorder is also depressed. So when you ask the question, more susceptible, I think that there are some disorders that in relationship tend to lend themselves, and they show up pretty frequently together. For me, one of the most startling ones is anorexia and alcoholism. Depression and anxiety, of course. So I mean, there are quite a few disorders that have a linked comorbidity. Can long-term stress cause permanent disorders? Yes, long-term stress can cause permanent disorders, especially if that stress is experienced when an individual is very young and going through those critical periods of physical and mental and social emotional development. If children are not empowered with the right regulatory experiences, they could have regulation issues as they get older. Oppositional defiance disorder, which is a disorder that gets classified in children, untreated, and it can be treated, but unrecognized and untreated can oftentimes mature into antisocial personality disorder in adulthood. Typically, an individual with antisocial personality disorder, we need to see those behaviors in childhood as well. And so when we think about how things can co-occur, and really what we see developmentally is that an individual would be diagnosed with oppositional defiance disorder, and then as an adult be identified with antisocial personality disorder. Exposures to stress, absolutely, especially during critical periods. Once you reach a certain age of maturity, socially, emotionally, and you guys just wrote about this, right? I mean, you know that there are critical thresholds for thinking development, for emotional development, and for physical development. And any exposure to stress, whether that's a toxin in your environment, whether you ingest it intentionally or you're exposed to it, or, I mean, we could even say emotionally toxic environments, all of those can lead to changes in brain functioning. One of the things that I want to stress, and I do believe that we have a question here before too long about curing things, and we'll get to that when we get there, but I think it's important to talk about that. Can people with comorbidity receive medication for each disease simultaneously? Yes. Oftentimes, people who are being treated for bipolar disorder will be on a mood stabilizer, something like lithium, as well as an antidepressant. What behaviors and mental processes differs psychosis from schizophrenia? Now, we'll talk about this today, and we'll see an example of that in the clinical video that we're going to watch. But quickly, schizophrenia is made up of a whole host of different disorders, different symptoms. Psychosis is one of them that is frequently seen, and it actually falls underneath the label of what we call a positive symptom, which means that there's something actively different or actively aberrant about that individual's perception of reality. Schizophrenia can also have negative symptoms as well as disorganized, and we'll talk about those today. I'll highlight that difference a little bit. What are the first steps someone should take if they think they could possibly have a disorder like bipolar disorder? My first suggestion is get with a mental health provider and simultaneously schedule an appointment with your primary health care physician. Any good diagnostic is going to start off with a full medical workup. A lot of times disorders represent, right? Like you could look at something and you're like, oh, that's a psychological issue. When in actuality, potassium levels could be off. Okay, there could be another hormonal issue. There could be a tumor on the pituitary. There could be, maybe some trauma to the amygdala when we're looking at emotional processing. So we want to do a full medical workup before we call it a psychological condition or issue. But definitely seek medical help, a medical professional as well as a psychological or a psychiatric professional. What are some treatments instead of medicine that can help bipolar disorder? Not a lot when it comes to bipolar disorder. We'll talk about the treatments specifically here in just a second, but there is some evidence that suggests that therapeutic intervention is helpful, specifically cognitive behavioral therapies, but this individual has to be pretty self-aware, and they also have to be really willing to participate in treatment. And like I mentioned on Monday, treating individuals with bipolar disorder tends to be our biggest hurdle just because of the issue with keeping individuals on their meds. Now, that's not common for all people with bipolar disorder. It is just a frequent issue. Okay, so the question about the disorders that we discussed on Monday, curable. There are a few psychological disorders that we are able to say that we actually cure where there is no additional maintenance of remission necessary. There are very few. Phobic disorders, there's still some maintenance required there. Mood disorders, bipolar disorder, absolutely. Obsessive compulsive disorder, absolutely. Typically, if an individual is dealing with a pretty significant psychological issue, cure is a big word. Cure is used when we talk about treating PTSD, which honestly surprised me when I learned this when I was teaching abnormal psych. I'm not a clinician. This isn't my area of expertise, but I taught abnormal psych for a period of time. And, you know, when you teach a class, you become a student of the class. And one of the things that I learned is that they do in this clinical realm talk about curing PTSD, because individuals with PTSD can reach a point where they are no longer symptomatic, nor do they need to participate in additional behavior suppression techniques, which is fascinating. What are the differences between bipolar 1 and bipolar 2? Let me share my other screen again. So bipolar is the green line. I'm going to put a red line in here. This is the other bipolar. The other bipolar, and I can't remember if it's 1 or 2. I want to say it's bipolar 2. It has what we call hypomania. They don't get up there to the same destructive extremes. We're going to call that bipolar. They don't get to the same destructive extremes. So they have what we call hypomania. So they don't get up into the hypermania. They just get to the point where they end up having an incredibly elevated affect. They end up having a lot of the symptoms that Mary had when she had flight of ideas. She was really optimistic. She, was a little bit reckless in her behaviors and how she treated other people and the injury that she caused. So the difference between those two bipolars is that one has hypermania and the other one has hypomania. All right, excellent. So how are we going to treat mood disorders? The first thing we start off with is mood stabilizer. This is typically used when we work with individuals with bipolar disorder. What we want to do is we want to shrink that distance, right? Remember the big sweeping lines that the green line made? What we want to do is we want to decrease the high and decrease the low. So we want to narrow everything down to what we referred to as the normative range of behavioral functioning, okay? That normative range is the sweet spot. That's really what we're shooting for with mood stabilizers. Of course, we also treat mood disorders with antidepressants, okay? And back in the day when I was a psychology student, we had 2 antidepressants. Prozac was one of them, and I don't even remember what the other one was. And now we have like so many different antidepressants. It's really varied. The reason why they keep inventing those things is because of the side effects. And then not everybody can take certain things, like certain people, pregnant people, people with different chemistries end up not functioning as well on the meds as they could. And so that's the reason why they keep reinventing. Now they've developed ones that have things like time release, where individuals can take a pill and it'll release over a longer period of time, but at a lower dose, so they're not taking as much. It's just continuously reinvented. And another treatment that is used very, very sparingly, like I mean like only in the most extreme situations of major depressive disorder. Remember that was that orange line that went right across the very bottom of negative affect, is electrical convulsive shock therapy. Okay, that's the ECT. Yes, it was wildly, wickedly popular for a period of time, and I know you guys have read the book, so you know that we've had a really messed up history when it comes to treating disorders. We have put people in asylums, we have done experiments on them. That's one of the reasons why we have an entire board of ethics anytime we want to do something. Anytime we want to say something's validated or scientifically supported, we have to take it through an internal review board in order to justify our ethics and our treatment of our patients. So electrical convulsive shock therapy really is only now used kind of as a last resort in treating major depressive disorder, even though it gets a hell of a lot more play in movies and media than is actually used in real life. So those first two, mood stabilizers and electrical convulsive shock therapy, are sort of the biological model, right? Let's treat the chemistry. The idea with the electrical convulsive shock therapy is much like a computer when things are weird and they're not functioning right. If we can do a hard reset, then it reboots everything and allows all the connections to be rewired and set up correctly. Well, the idea with ECT is that because your neurons have both chemical and electrical communication, ECT is working on trying to do a hard restart, for lack of a better analogy, on the electrical part of your neurons' communication. Chemical is what happens between the neurons, and electrical is what happens within the neurons. So the mood stabilizers work between the neurons, ECT works along the neuron, and then it comes to psychotherapy, okay? And the bread and butter, right? And this isn't the best case scenario. We're seeing a lot of advances in therapeutic practice related to mindfulness training. And really so many of the things that we're seeing are kind of a spin-off of cognitive behavioral therapy. Now, if everything about a functioning human being is about thinking, feeling, and behaving, cognitive behavioral therapy is dealing with the behaviors and the thoughts. And so we want to target what you're doing that's not okay. Okay, so let's say you have OCD and you're a checker, which means that you're somebody that is always worried about things being locked or things being turned off or sharp objects being placed away appropriately. And you are a checker in that you find that you are unable to engage in life until you are assured repeatedly that the door is locked. So you check it, and then you check it again, and then you check it again, and then you check it again. And then you get halfway to work and you turn around and drive back and you check it again, okay? Right? Those fit with deviance, distress, and dysfunction because it impairs your life. It keeps you from being able to get work on time. It's distressing because you don't like the behavior. You know that it's not okay, okay? And it's considered deviant because, you know, in your brain, in your memory, you should be able to know that you lock the door and be good with that, right? And there are some people who will lock the door, take a picture of it with like a selfie of themselves with it, time-stamped and everything, and they'll doubt the photo, okay? They'll doubt the photo. And so for these individuals, we might work with them in treating them. And in this treatment modality, we might say, okay, you're allowed to, how many times do you normally check? And they say, I check the door 7 times. We say, okay, you're allowed to check 6 this week. You can't check any more than 6. Okay, so behaviorally, we're curbing the unnecessary behavior. But then we also deal with the cognitive, with the thoughts. Okay, what could you do? What could you say? What could you create in your environment that would be reassuring for you to know that you actually did lock the door? Okay, so in cognitive behavioral therapy, we're working on both the behavior and the thought. One of the reasons why we're seeing sort of this sort of resurgence of mindfulness is because now we have clinical neuroscience. We have clinical neuroscience, which allows us to study the impact on the brain of meditation and of mindfulness. And we get to see the benefits for individuals. And I have 2 friends of mine. They've been at Columbia. They've been at Harvard. No, wait. They've been at Columbia. Yeah, Columbia, Harvard, and now they're at Vanderbilt. I think they're getting ready to wrap up there and move up to Canada. But they're both cognitive neuroscientists. She's a clinical cognitive scientist, and he is a cognitive neuroscientist. And he gives like PowerPoints to His Holiness the Dalai Lama. It is the most badass thing I've ever heard of in my life. He just like loves it, and I think it's awesome. But his entire agenda is studying monks' brains and understanding how their life course of contemplation, meditation, surrender, detachment in a positive way, not in a defensive way, how all of these spiritual principles that they practice result in them having such amazing health. I mean, that's really at the bottom line is what they have. Is they have amazing health. They have an amazing longevity, and they also don't have very much disease, cognitive disease specifically. Yeah, psychological disorders. So it's fascinating stuff, and I can imagine that when I'm lecturing about this content, it'll be folded into our book within the next years. I don't know, I'd say 5 years max. And in addition to psychological therapies, I'll have mindfulness training as well. All right. So I wanted to remind you of our 3Ds: deviance, distress, and dysfunction. And then, of course, we always have this danger. And remember, distress could be experienced by the client, right? The individual with the disorder. Distress can be experienced by them. Oftentimes, like we're going to talk about Etta today, she did not have very much awareness of the impact that she was having on her environment. And so her behavior was distressing to others. Okay, her behavior was distressing to others. And that's what made it so unique. I'm gonna toss you guys into a breakout room really quick. And what I want you to do is, I'm only gonna give you 5 minutes, so make it a quick talk. But I want you to try to think of everything that you've seen in media, everything that you've read, including our textbook, and try to come up with a good exhaustive list of symptoms of schizophrenia. And this is just to the best of your knowledge. My expectations here are that you get to strive for 5 minutes to really try to work on that. Okay? So Hannah, will you pop that into the chat if you haven't already? Excellent. Thank you very much. Okay, I'm going to send you into these breakout rooms, and I'll see you at 2:05. Remember to let me know if your people aren't chatting, so I know which room to get in trouble, and so I can move you to a place where you can be effective.
Dr. Henderson, I wasn't put into a room.
Who are you?
Skylar.
Skylar Downs.
I didn't get an invitation.
Okay, well, let me see where you were supposed to go. So check to see what browsers you have open, because a lot of times the invites get hidden. And now work your mouse around your Zoom control panel and see what pops up there, because oftentimes it's just you have to move it to the right spot and it'll pop up for you. And I am still looking for you, Skylar.
I'm also not in a breakout room, and I've kind of sorted through my computer and Zoom and everything.
Okay.
Yeah, I'm in the same boat.
All right, all right.
And then nobody was talking in my breakout room.
Yeah, sorry, I just came in. No one was talking in mine either.
Excellent.
Thank you.
Gotta love that, you guys. All right, bear with me. Well, why don't we just talk right now? What, since we're all here together, everybody turn your mics on. All right, what are the symptoms of schizophrenia?
Something that I've noticed, like especially in media, is like a lot of like intrusive thoughts, auditory hallucinations, visual hallucinations, just kind of erratic behavior in general.
Okay.
hmm
Notice people are
So,
really paranoid sometimes.
Yeah, that's what I was gonna say.
and when you say paranoid, how, like, what does that look like? What are some of the specific behaviors that you see or thoughts?
Like they could think that people are following them or like out to get them like most times, and that they like weren't safe where they were.
Okay. Because in
Yeah, like they're
schizophrenia,
just cautious about kind of like their environment, and they're like they have a belief that like there's others or there's like other voices and stuff, and they're seeing or hearing things that aren't actually there.
okay. Well, I appreciate that take on it because when we think about schizophrenia, the paranoia piece of it is it's all part of the thought disorder, right? Regular information is coming in, but it's all being interpreted as being threatening, and that's where it can become a significant issue. So you guys talked about hearing things, seeing things. You talked about paranoia. What's another symptom of schizophrenia that you can think of?
Don't they have kind of unusual motor behaviors sometimes, like the catatonic behavior?
Oh, so the suggestion that sometimes they can have catatonic behaviors, and that's actually one of our negative symptoms, where an individual doesn't move normally or might be kind of jerky. The other thing that we run into is that a lot of antipsychotics, a side effect of that is what we call tardive dyskinesia, which are abnormal hand movements, like abnormal movements of the body. So there's two different ways that you could think about that one. Good suggestion. All right, give me one more, and then I'm going to close all rooms.
Isn't reduction in speech, isn't that one of them?
Yes, right. And when you say reduction in speech, what do you mean?
Like they kind of stop talking to the real people.
Okay, so they stop having normative interactions, but you also qualified that by saying they stop talking to real people. Does that mean that they still talk but to people who might not exist?
That's a good question.
No worries, no worries. One that we'll probably get to tackle here in just a minute. I'm going to close all rooms. Good job, you guys, for talking to the big scary professor.
Thank you.
I appreciate it, and thanks for working with this. I mean, we're still learning how to make sure that everybody gets what they need out of these experiences. We'll keep working on it. I appreciate your patience. All right, folks, go ahead and mute up again when you're coming back in. Thank you very much. For those of you that are not engaging in spaces and places, my suggestion to you is do your peers a solid. And when I see that you're the only person in the discussion room, yeah, I know you're not talking to anybody. And when I see that everybody else has left your discussion room and you're still sitting in your discussion room, yeah, that means that you're actually not engaged. And I can start calling out a few people, but I don't know. Maybe next time I offer this class, I'll have to figure out a way to be punitive with people not engaging, but I definitely don't want to be the fun police. I'm already enough of the police to begin with. Uh-oh. All right, so go ahead and throw in the chat. It's okay, it's gonna be hodgepodge, it's gonna be crazy, there's gonna be lots of words. Go ahead and throw in the chat some symptoms that you guys came up with. Hallucinations, paranoid delusions, agitation, hearing voices, disassociating, delusions of all kinds, voices. You can have delusions of grandeur, where you believe that you have magical powers. You can have delusions of persecution, which oftentimes the paranoia falls underneath that. You can also have delusions of erotomania, where you believe like anybody who talks to you, anybody who looks at you is attracted to you. Sometimes we see that in borderline personality disorder, which is typically for females. But this sense or this mistaken belief that everybody's interested in me is very different. Messiah complex. Alogia, thank you for that word, Mia. I really appreciate that. Problems with social functioning, right? That definitely falls underneath that deviance and that distress. Blowing normal events out of proportion, right? There's definitely a misperception of reality. You guys did a great job. All right. what I want to do is I told you that we had different sort of classifications of symptoms for schizophrenia, and I want to break them down for you a little bit. We have positive symptoms, we have negative symptoms, and then we have disorganized symptoms. The positive symptoms are what a lot of you touched on, which is the psychosis, which is the delusions and the hallucinations. Now, delusions are the thoughts that I have powers, that people love me, that I'm being persecuted, right? Delusions are those thoughts. Hallucinations are sensory experiences absent of sensory stimuli. So oftentimes individuals who are experiencing a psychotic episode, they can say, I smell my aunt's Chanel No. 5 perfume. And what happens is that when we put these individuals into an MRI machine and we say, are you experiencing any sensory experiences right now? And they can say, yes, I can see my grandma Hattie right now. She's standing right in front of me. And what we see on the brain scan is we see the occipital lobe, right? The part of our brain that's responsible for perceiving sight. And but there's no change in vision, right? I mean, their eyes are closed, their vision is blocked. There's no change in light, so there's no actual light waves coming in. Similarly, when we have an auditory hallucination, the temporal lobe lights up. Sorry, the temporal lobe on this side lights up, but there's no change in the cilia in the ear, right? There's no change in pressure, right? Sound is conducted by radio waves, right? By auditory waves, pressure changes. And those individuals report hearing things when there's actually been no pressure change to the auditory system at all. So this is where antipsychotic meds come in. We'll talk about the treatment of schizophrenia, but just in case we go a little bit long in the conversation in another direction, I want to point out that when we're treating individuals with psychosis, with delusions and hallucinations, and we use antipsychotics, we run into a side effect called Tardive Dyskinesia, which are involuntary hand movements. And you're going to see those in this film with Etta here in just a minute. So positive symptoms typically are represented by psychosis, the delusions and the hallucinations. Negative symptoms, this was mentioned by, I think it was Mia. Mia mentioned alogia. And this is not speaking, okay? Positive symptoms means there's something that is divergent, that is added to the environment, right? Delusions and hallucinations. Negative symptoms are behaviors and thought processes and feelings that are removed from normal practices. So when I think about positive symptoms, I think of sort of normal things blown out of proportion. And when I think of negative symptoms, I think of normal things that have been removed. In our culture, unless you have like a structural impairment or there's another issue with you anatomically, you're going to be a talker. You're going to speak. Like if you're of a certain age and ability, you're going to talk. So not having speech is pretty significant. The other thing that we see is flat affect with individuals who have schizophrenia. And the people that were in my group mentioned catatonic states. And catatonic states, there's definitely alogia. And if they do speak, their affect is really super flat and totally monotone. True story, and when I used to teach abnormal psychology, I would come in on the night of schizophrenia and I would act schizophrenic, like I would represent the symptoms and I would have the students try to figure it out. And then thank the heavens, we got clinical videos. But I had students that were so concerned about me, you know, I mean, because I'm a pretty dynamic, I have varied affect, but I would come in and I would try to speak in a monotone, and I'd never made it very long at all. Other negative symptoms that we see, anhedonia, which is something that we also see in depressive states. It basically means a lack of pleasure, a lack of joy, an absence of positivity. And so that's another negative symptom. Some disorganized symptoms, and this is just a little bit of a catch-all, and this is when it's not the presence of something aberrant, it's not the absence of something normal, it is very clearly something that is not following the linear expectation of our culture. So when I talk about disorganized language, this could be what we call word salad, where individuals just say words and connect them when logically they make no sense. They're literally just a salad. words are just thrown together. There's really no association that we can see between them. We also have tangentiality, where an individual could be asked a specific question and they can just go off on a tangent. Now, I know lots of people, including myself, that can go off on tangents for days. That does not mean that we're schizophrenic. That is just part of it. And they're incredibly, incredibly incoherent. And the other sort of catch-all with disorganized symptoms is affect and behavior. So an individual would have disorganized symptoms affectively if they were at a funeral and they made a joke of it. Okay, that would definitely be a red flag of sorts. And then behaviorally, they would do things that seem nonsensical. And I think culturally, one of the iconic behaviors is wrapping your head in aluminum foil. All right. What I want you to do is I want you to keep in mind the positive, negative, and disorganized symptoms, and we are going to watch some of EDA. Remember to be mindful and respectful in the chat. Be aware of your language. It's really important that we don't use any degrading terminology, because I'll guarantee you, statistically speaking, out of 203 people in this class, we have at least 25 people in here whose lives are impacted by schizophrenia. So please keep that in mind and be respectful. And that is not where I wanted to go. Play this video.
Suffers in a profound way from schizophrenia. Schizophrenia is one of the most severe mental disorders. It's usually a lifelong disorder with periods of psychosis. In some cases, like Eda's, these periods of psychosis can go on uninterrupted for years. Also notice that in Eda's case, her disorganization of thinking is so profound, it makes it difficult to ask about other symptoms.
I want to thank you for coming down this morning, and you and I have had plenty of chance to have conversations before, but this is our first one on video. What went on that you ended up coming into the hospital?
Well, Jesus was giving me all these window crack things, screen crack sounds, telling me that they was going to break into the house. So I put the camera stereo in the room where they chiseled the window out to come through the window.
Mm-hmm.
And the camera stereo, the security guards picked that up, the message, by putting that camera in that room.
Mm-hmm. Were you in danger?
Well, if anyone gets into the house, they said I get shot.
Who said?
That's the eagle.
Can you say a little something about the eagle?
Well, the eagle works through General Motors. They have something to do with my General Motors check I get every month.
Mm-hmm. And you get that check because it's part of your husband's work with GM?
Yes.
Say something more about the relationship between GM and the eagle.
Well, when you do the 25 of the clock, it means that you leave the house 25 after 1 to mail letters, so that they can check on you how you're mailing the mail, and they know where you're at that time.
And who's they?
That's the eagle.
Okay. And is the eagle something that is looking out after you, or is there a chance that the eagle could hurt you?
Well, they're the before on the clock. That's the 6, 7, 8, 9, 10, 11, 12, 1, 2, and 3. They go by those numbers of the clock.
Mm-hmm.
And when you do the 25 after, that's the after side of the clock. We go by the 1, 2, 3, 4, and 5 of the clock.
Mm-hmm.
And the 5, you go right, left to 7 number on the clock is the fire number. You go right, left to that number.
Mm-hmm.
That's what the 25 is. If you don't do something they tell you to do, and Jesus makes the shotgun sound, and then the phone rang, not to answer the phone or the doorbell.
Why not?
because you get shot.
Who would do the shooting?
The eagle.
Now, I remember when you first came in, were you seeing some visions on the floor?
No, I was just confused. You know, first they didn't tell me why I was in there.
Mm-hmm.
You know, but the security guards came and they were very nice to me. I wasn't handcuffed.
Can you say more about the things that were happening at home?
Well, when Jesus made the shotgun sound and then the phone rang, not to answer the phone or the doorbell, I knew it was Jesus talking to me. And he floated. I seen a Kmart bag float down from my ceiling to the floor. That's probably what you was thinking about.
Yeah, no, tell me about that.
Well, he made the sound of a bag opening up, you know.
Mm-hmm.
And I had my back turned to the bag,
Mm-hmm.
and I was sleeping. And when I heard the bag open, Jesus wanted me to look at the Kmart bag floating down from the ceiling to the floor.
I'm wondering, though, whether these kinds of experiences that you have are really unique to you, whether there's something special about your relationship with Jesus, or whether this is the kind of relationship that other people may be having too.
Well,
what's your personal feeling about that?
Well, I'm not. I don't like to judge anybody.
I know. I know. I'm asking you a tough question. And I don't want to put you in the position of feeling that you're having to brag or put anybody else down. Do you think Jesus...
Okay. So what I'm going to have you guys do now is I'm going to send you into breakout rooms. And I feel like if y'all can debrief together and walk through this, what I'm going to do is I'm going to post to you. I've got to exit out of that really quick. I'm going to post to you a link to a Google Doc. Can you hear me?
Yes.
Okay. All right. Thank you. I thought I heard somebody say turn on your mic. So what I'm going to have you do is I'm going to copy this entire dialogue and just send it to you here. What I want you to do is I want you to organize using that link. I want you to work together as a group to categorize and identify at least one symptom for each category. The amazing thing about Etta as an example is that she has all of the above. Like she has a positive, a negative, as well as disorganized symptoms. So I'm going to go ahead and put that back up here. So you can screenshot that if you didn't write it down, but you have all of that information and everybody's got that in that chat. So go ahead and head out to your breakout rooms and let me know if you have any questions.
Dr. Henderson, I wasn't put in a group.
Why doesn't?
Also, I don't know. It's
Yeah,
the
I'm
same
still not in a
kind of
breakout room.
people. I think apparently we're just in a group together.
Okay, well, guess what? We are our group now. Elizabeth, will you go ahead and lead the convo here? I'll tap out so I'm not too much of a distraction. I'll tap out. Go ahead and lead the convo, Elizabeth.
I just got a request to join a breakout room. Do you still want me to stay here?
Yes.
Yes?
Yes, ignore it and stay here.
Okay.
Okay.
Okay. So we're categorizing these symptoms into the 3 Ds. So what do you guys think?
You want to put the symptoms into positive, negative, or disorganized.
There we go. Okay. Okay. Emma, do you want to start?
Okay. In the 3Ds, I would say, let me think. Trying to think. I'm not sure.
On our, like in the chat, she has a link, and if you click on that, it has like a little table that we can fill out.
Okay, let's do that. I can do that. Okay. Well, let's look. Would I make it a copy of it, and then?
Yeah, or you can just say them if you don't want to.
About it.
Yeah.
Perfect. Okay. So positive symptoms. The symptoms. She definitely had or actually I'm gonna do negative symptoms. I think she had a. Would that be like she had catatonic movements, or would that not be catatonic? That would be like alogia, where she like was moving her hands. Is that? Am I right on that, or is that called something else?
I'm having trouble hearing. Were you just talking?
Yes. Can you not
And
hear
can
me?
you guys hear me?
Yeah.
I can hear you.
Alogia would be a negative symptom. Can you hear me?
I can't hear anything. Okay.
I can hear
I
her.
can hear
She said
you, but it's really, really quiet.
I'm pretty sure she was talking about how her like the movement and the girls.
Delaney, can you hear me?
Yeah, I can hear you.
I can hear you.
I can't hear you. I see your guys is like.
No one was talking in my breakout room.
I can hear you.
I love that.
Should I be moved into the breakout room?
No, we're gonna leave you right here, and you're gonna have to talk to us. How scary is that? All right, so let's do it this way. What was a positive symptom that you guys saw?
She definitely was having like auditory hallucinations, so that's adding something to her environment.
Excellent, excellent. So which one is that?
That would be positive.
Positive. And how might that be deviant, distressful, or create some dysfunction?
That's definitely deviant from what's considered like normal behavior, because people don't generally like have auditory hallucinations.
Yes.
Nowhere.
Yes, yes. And Emma had said, I was able to hear Emma a little bit, and she was showing alogia, which is that very disjointed. I mean, normally alogia means no speaking whatsoever. So I don't know. I wouldn't say it's alogia. I would say that she had flat affect for sure, because she was speaking so monotone, which is one of those negative symptoms. But there was something else that she had in her way of speech. What was thank you, Emma. What did she have in her speech that was kind of disorganized? Was anybody able to follow what she was saying?
There was definitely like some things that were missing from her sentences.
Some
like,
things? Everything.
Yeah, well, yeah, mostly. But I mean, I don't know what it's called, but like that was kind of an obvious.
Disorganized thinking a lot.
Absolutely, absolutely. And I mean, and that is what we talk about when we talk about disorganized, right? I mean, she is a stereotypical example of word salad, like the eagles and the dogs and the cracks and the windows and the 12 and the clock and the, you know what I mean? Like, I mean, that is definitely out there. Somebody had asked in the chat, what was she talking about? And I don't know. Everything makes sense for her, and the amazing thing is that for these individuals, their line of thinking stays the same. Like they can repeat back to you the same jumbledness time and time again. And it just makes perfect sense to them. I just want to applaud all of you for working hard and to make this discussion happen, even through all the technological issues. I know this isn't easy, and I really genuinely appreciate your effort. So don't forget to mute up. People are coming back.
Dr. Henderson, I have a question.
Go ahead, Kellen.
Have you ever seen the movie A Beautiful Mind?
Yes.
Oh, it's so good.
Is it real? Not really. John Nash is an incredibly unique and gifted individual to be able to manage his schizophrenia, because his delusion are these people, and he manages his schizophrenia in a way that is unlike what we've seen most people do. But remember, he's also like a really amazing mathematician and everything else like that. So he already has sort of a gifted degree of consciousness. So he could like logic his words. So yeah, it's pretty amazing. It's a great story. And the story goes on, his son actually has schizophrenia as well.
Oh, did they make a second one?
No, they didn't make us, but his real life, like where the story leaves off with him winning the Nobel Peace Prize. I mean, he's lived well beyond that. And since then, right, his son has schizophrenia and is exponentially less effective than his dad. So it's pretty sad. Pretty sad. No, you don't need to send me the diagram. Not this time. I'm hoping to reach a point where you'll be able to submit them for like participation points. Maybe not this semester, but some semester in the near future if we're still living life via Zoom. Schizophrenia, it's a pretty dynamic disorder. It is very overwhelming, very challenging, and very difficult to treat. So when we talk about treating schizophrenia, the first thing that we start off with is antipsychotic meds. If they have that positive symptom of psychosis, we need to give them antipsychotic meds. And like I mentioned, that side effect that Etta demonstrated with the rolling of her fingers, that rolling of the fingers is a side effect of the antipsychotic meds. Just remember, positive symptoms are behaviors that are present that are really abnormal. Negative symptoms are normal behaviors that are absent, like speaking, varied affect, eye contact, emotional engagement. In treating schizophrenia, we also do psychological therapy. And we've seen individuals experience great success in group homes, especially group homes where we have environmental constraints, and we help those individuals through what we call a token economy, which really is using positive reinforcement from that operant conditioning. So every time an individual does something that is socially appropriate, correctly engaging, hey, Austin, you're not muted. They receive a token, right? And they get to add up these tokens, and then they get to do something fantastic with it. And when they get to do something fantastic with those tokens, what they have for themselves is they have sort of an economy, a token economy, where they can earn more tokens through appropriate behavior. And you'd be amazed at how much behavior management you can do with individuals who have schizophrenia. They normally have to be higher functioning schizophrenic individuals in order for this token economy to be effective for them. All right, folks, please enjoy your weekend. Remember, you've got a unit essay that's active. Your grade will be posted here at 2:45. And until Monday, that's the riskiest thing I do today. It used to be using the word fuck all the time in class, and now I take off my mask and smile at people. Have an awesome weekend. Be safe. Make good choices. Take care.
Thank you so much.
Thank you.
Thank
you.
Bye.
Thank you.
Thank you. Have a great rest of your day.
Bye.
Have an awesome weekend. Be
Up to
safe.
you.
Oh, shit.
Dr. Henderson, I have a question.
I do too.
Yes, go ahead. Give me a question.
Okay. Well, hello. Hi. I sent a question in the chat right before we went to our last breakout room.
Okay.
From the clinical video of Etta, my question is, can people with severe schizophrenia her case is, comprehensively understanding what people are saying, but just can't reply in a comprehensive manner? Or is it like miscommunication on both ways?
So for Etta, she believes that she is answering the question you ask. Right?
Gotcha.
You say, what time is it? And when she says 12 of the clock and the grocery shopping and the money and all that stuff, she genuinely believes that she is engaging with you. And so there's no distortion on her part. For her, she's communicating effectively and clearly.
Gotcha. Okay.
Yeah.
Thank you.
You bet.
Quick question.
You bet.
From up in the library up here. Hi. So I usually do the weekly essay just because it helps me prep for the rest of them.
Yes, yes,
Is that an extra credit thing, or just will there even be a prompt this time around or not?
No, extra credit. Extra
Okay,
credit
cool,
this week.
cool.
Yes,
Awesome.
yes. Absolutely.
I like to do it. Okay, thanks so much.
Good. Good on you.
Yeah.
All right, what's next, folks?
I have a question.
Excellent. Sock it to me.
So, this is about like drugs and like personality stuff.
Okay.
When people are hallucinating on like their acid and like stuff like that, every person sees something different. Do you think that has to do with like their psychology or like their way their brain works or like their mental state or anything like that?
Absolutely. Like you've heard about a bad trip. A lot dictates what happens when you take the psilocybin, like whatever hallucinogenic. Marijuana is considered a hallucinogenic, so your pre-mood is going to inform the trip that you have. And so, yes, there are mood states that inform that. There are also personality variables that inform that. So if you're an individual and you have hostile misattribution bias, where like anything happens and you perceive it as negatively, you're going to be a holy terror to deal with and navigate during an episode. Yeah, good question, fair question. I don't mind answering questions about drugs. Make good choices.
I asked it like at the beginning of class and I was like, she didn't answer it. No.
There we go. We got it covered.
All right. Well, thank you.
Thank you.
You have a lot of questions today. I have one as well, if that's
okay.
all right.
Sock it to me.
So going into this, I was looking into something else recently. What Elon Musk is doing with the Neuralink that he's coming out with, and I'm not sure if you're familiar with it, but what he's trying to do is something that physically attaches to the brain, and he's trying to make it so he can fix psychological disorders and disorders in people.
Okay.
And I was wondering is that something that's been done in psychology ever before, or is that something completely new? Like physically trying to change the brain.
What do you think a lobotomy is? I
Yeah,
mean, a lobotomy is when you go in through the occipital lobe or you go up through the nasal cavity and you remove part of the frontal lobe. It's not new information. We've put in stimulus receivers for individuals who have epilepsy, individuals who have depression. We've put electrodes permanently in their brain that they can press periodically in order to have them behavior or mood correct. So no, it's not new.
Okay.
It's fascinating, but it's not new.
Yeah, it's pretty cool, but yeah.
Yeah,
kind of scary too.
Good question, Austin. I know it is kind of scary. It's not a choice I'd make.
Yeah.
Take care.
Yeah, you too.
Megan, Annie, do either of you have questions, or are you just ghosts of individuals that are not actually there?
I did have a question,
okay,
but
Megan.
you kind of just answered it. So.
Oh, good. Awesome.
Yeah.
Perfect.
Okay. Bye.
Take care.
Yeah, I was going to get an answer question, but I got it answered. So thank you so much.
You got it. Take care, Annie. Thank you.
Bye.
Bye, Logan.